So welcome to the Adoption and Fostering Journal podcast. And I'm Vicky Walker, the production editor, with Dennis Golm, the editor-in-chief. And we're joined by two wonderful guests today. We're really delighted to have them, Matt Woolgar and Tom Cawthorne. We're going to introduce our guests in a moment, but just sort of first off to say that we are discussing the health notes from the July issue of Adoption and Fostering. So that's volume 49, issue 2. Which is available to Core and Bath members for free as part of their membership. So do look into that if you are a part of an organisation who is a member of Core and Bath. And we're also talking about a letter to the editor, but we'll go into all of that in more detail. So just first off to hand over to Dennis to introduce our guests.
Yes, well, actually, I'm a bit cheeky about it because I always prefer asking our guests to introduce themselves. So
Yes.
that's anything very important, so I don't forget any important detail. And it also, it makes you human if you introduce yourself to our guests. So maybe if you start with you, Matt.
Yeah, hi, I'm Matt Woolgar. I'm a consultant clinical psychologist, and I have worked in the National Adoption and Fostering Clinic at the Maudsley for over 20 years. Unfortunately, that clinic has just been deemed earmarked for closure, so which is a shame. Maybe we'll talk about some of those issues later. And also another number of things I do, but one thing I'd like to also flag up is that I am an attachment researcher. I've been for 35 years an attachment researcher. I live and breathe attachment ideas. I think it's important, just in case sometimes people think I'm coming across as not a fan of attachment. I love it. It just may mean that I have a slightly different take on it to other people. So I'm a clinical psychologist with an attachment hat on.
So Tom, what hat are you wearing?
Great. My name's Tom Cawthorne, and I was the senior clinical psychologist in the National Adoption and Fostering team, working with Matt until it was sadly closed. And I'm now actually working with Matt on a separate clinic, which we've set up called the Child Wellbeing Clinic, so we can still continue to provide ASF supported work to the families that we were working with previously in the NHS. And I'm also doing a fellowship from September based at King's College London around how we can improve the mental health outcomes of looked after children. So this is also an area that I'm really passionate about as well. So thank you very much for having us.
That's wonderful. And just before I forget, I'm going to mention the title of the health notes. So the need for improved recognition of neurodevelopmental conditions in adopted and fostered young people. So that's the topic that we're talking about today. And Dennis, full disclosure, this is a sort of area of interest for you, isn't it?
Yes, so in my kind of day job, where I do research on childhood abuse, neglect, and one of my core areas is kind of the intersectionality or overlap with new developmental diagnosis. So I'm very happy about this podcast topic today. And maybe if we get right into it, because in the health notes, we just mentioned, you say that certain needs, we're not going to say which needs just now, are overdiagnosed, while other quite important needs are underdiagnosed. And could you explain what needs you're referring to, and maybe also what problems could arise from that?
I think one thing that we've really recognised in our clinic, and I think is also really backed by research as well, is we know there's a real kind of tendency to focus on kind of attachment disorders and difficulties and trauma. And whilst that's really, really important for this population, of course, it's really, really key to have that perspective. We also know it's not the only relevant perspective. And actually, there's a lot of data that supports the fact that young people who are care experienced are more likely to present with neurodevelopmental conditions such as autism and ADHD. And that's something we've seen a lot within the National Adoption and Fostering team. And I think the real challenge is when that's being missed, which so often it is very sadly at the moment, then these young people are not getting the specialist support that they need, and the adapted support, whether that's in terms of therapeutic intervention, medication management for ADHD, for example, or thinking about schools, so how there can be kind of evidence-based adaptive strategies being implemented in schools. And really sadly, that's often missing, and I think is really contributing to many of these young people having poor outcomes, which is, really, really sad for them and their families.
And I wonder whether it's worth, just for the sake of our listeners, or maybe people who might be prospective adopters, maybe just to clarify maybe the difference between attachment disorders and attachment patterns.
Well, can I do that?
Yes.
Yeah, it's an interesting distinction. I mean, maybe the place to start is the idea or the recognition that whenever a child is moving to a new home, to adopted family, to SGO or to foster care, they've got the developmental task of forming new attachment relationships. Attachment's always in play. It's always going to be important. But as and I know Dennis knows this very well from the research he used to do with the ERA studies, that's quite different to thinking about attachment pathology, attachment disorders. There are 1.5 attachment disorders. There's reactive attachment disorder and disinhibited social engagement disorder, and they're very specific disorders that can be diagnosed in a very formal way and are probably really quite rare, even in the care experience population. We kind of know they're quite rare if they're diagnosed effectively, and they're quite unusual presentations. Whereas attachment patterns, we've all had attachment figures. We all have a type or quality of relationship with that attachment figure, broadly understood as secure or insecure, organized or disorganized. So various ways of carving the quality of that relationship up. It's quite normal to have variation there. And in fact, in a recent very large meta-analysis, which suggested that it's pretty normal to have an insecure attachment pattern in the normal population, not just in the care experience population. It's about half and half. It's maybe 51% of people were secure in infancy and about 49 insecure. So let's think about attachment patterns as part of the normal variation and the quality of relationship with the attachment figures. Whereas the attachment pathologies, difficulties, they're something quite specific and different. And I won't go into defining them now because, well, I'm happy to, but I think that may not be what your listeners particularly want right now. But maybe we could put a resource for people to read about that if they're interested in it, because it is a fascinating area. And I know the work of the ERA studies, the English Romanian adoption studies, and Charlie Zena's Bucharest studies really changed our thinking about attachment pathologies in the last 15, 20 years. And hopefully clinicians have caught up with those changes.
I just thought it might be good to kind of clarify what we're talking about when we mean kind of attachment in terms of disorder pathology, and that we're not referring to attachment patterns, right? So talking about new developmental diagnoses amongst kind of care experienced children and young people, one thing I think, or one question I find quite interesting is what could explain this higher prevalence within that particular population?
I'll start on that, and it probably the simplest way to think about it is that these children are drawn from a very particular sample, and they're not randomly drawn from the wider population. They're drawn from a cohort of families who've had usually a range of difficulties, and some of those difficulties are going to include mental health issues at an elevated rate compared to the non-care experience cohort. So there's going to be, I mean, autism, ADHD, we know they've got a strong genetic component feeding through. So just some simple thinking about heritability, they're going to be more likely to have those difficulties. And then overlaid on that, it's not just genes that cause these issues. We know there's a bit of, there's some fairly significant environmental stuff in play as well. So the chances are their environments are going to take any trait genetic liability and maybe probably increase it rather than decrease it, the likelihood of expression. So we shouldn't be surprised to think that this is going to be a cohort who could have more problems than other cohorts. And actually in our clinic, thinking about it, we got some data that showed about of the children we assessed coming in through the Adoption Support Fund, for example, around about 2/3 had undiagnosed neurodivergence of some form. It was like one of the most common presentations, and I guess that's partly because there was aspects of their presentation, quality of their difficulties that wasn't being effectively understood in terms of, say, attachment and trauma, and these are the families who are seeking out further understanding, and we just saw a lot of undiagnosed neurodivergence, and it's not surprising.
I guess the other maybe type of diagnosis, I'm thinking about kind of fetal outcome spectrum disorders, which are right range of potential difficulties in terms of presentation, and obviously one domain, kind of alcohol when consumed kind of during pregnancy can affect is the development of kind of attention regulation or attention networks in the brain. So can we still diagnose, for instance, let's say ADHD if a child already has a diagnosis of, say, FASD?
I would definitely say yes, because these things don't exist in isolation. Again, you could think about the cohort of families where children are more likely to have been exposed to fetal toxins, including, but maybe not restricted to, alcohol. There may be some parental genetic differences, genetic liabilities in the mix as well. We know people with ADHD may be inclined to self-medicate if they're not getting effectively assessed as adults. So, there are all sorts of reasons to expect why the cohort of people who are exposed are more likely, it's not a one-to-one mapping, but are more likely to be exposing children to fetal toxins, including alcohol, are going to have their own issues. So some of that's going to be directly inherited and exacerbated by lifestyle characteristics as well, potentially. If postnatally those families might be more chaotic and the postnatal environment might be more traumatic. There's more stuff going on in the development of the human fetus than just whether or not there's been alcohol or other drugs ingested. They're not being raised in laboratory rat conditions. They're being raised in the normal, messy, well, maybe abnormally messy and chaotic lives of the birth family. So there's lots of potential stuff contributing to that child's specific outcome. And actually, I always say when a child's got a diagnosis of fetal alcohol or other, I say other fetal toxins as well, because it's not the only thing that it's been shown to influence, fetal development and later child outcome as well. But whatever, if they have that, it's really the start of the assessment journey. I mean, there's such a spectrum of ways in which alcohol could potentially have affected a child that if you then go on and assess the specific needs of that individual child, they'll often come up to be quite different. I mean, I remember one time in a pre-adoption, we were doing a series of pre-adoption assessments. We had 3 children in a row who were toddlers who'd been correctly identified as having fetal alcohol conditions, and they're so different. And their specific needs and the needs that the adopters would have to sort of be meeting were quite different. So the fetal alcohol itself was an important part of the mix, but the children were still individuals. And they still need to be understood as quite different and distinct from each other. And I think that's the neurodivergence. It's about difference, really, and there's a lot of difference amongst neurodivergence as well. So let's not just stop the assessment process once one thing's been identified. We need to keep it running.
And I think just building on that, I think that's kind of key, and what we feel so passionately about is that diversity, that actually we can't put these things down to a single factor because everything interacts. Parents who are, as Matt said, more likely to engage in substance misuse during pregnancy are also themselves more likely to have mental health problems, or more likely to have experienced trauma, or more likely to be neurodiverse. And all of those things are going to interact. And therefore, we can't ever say it's just one thing. And I think, often with the kids we've seen in the clinic, people have said, oh, it's just this one issue. And if we just focus on attachment or just focus on fetal alcohol syndrome, everything will be fine. But actually, that's not the reality, because we need to think about this more complex picture and then be able to provide something more nuanced than that. And I think that's so key.
Brilliant. And of course, I absolutely agree. And it makes me want to spin off and talk a bit more about why do people do that? What is it that makes people want to take what is actually, we know, to be a really complex presentation? We know that if you're exposed to maltreatment, then your child maltreatment, then the likelihood of is raised across all possible mental health disorders by a little bit, but across everything. So we should expect early adversity breeds diversity. But what is it that keeps happening? Why is it that people keep trying to give one explanation, one top-down explanation to explain what we know is a really diverse set of presentations? And whether it's fetal alcohol, whether it's attachment, whether it's trauma, whether it's sensory integration, it doesn't really matter. Whether it's autism, even, whatever the category people use to obliterate difference and diversity is potentially really unhelpful. And it operates across attachment, trauma, sometimes fetal alcohol, sometimes even psychiatric diagnosis. Some would argue especially across psychiatric diagnosis. So I think we have to be really careful not to buy into models that take complex individuals and just lump them into one bin, one category, because that's the way of this term people may have come across, diagnostic overshadowing, the idea that you give this one headline feature of the person, and that kind of casts a shadow over all other possibilities. We don't want to do that. We want to make sure that we're still keeping an open mind to all the ways in which that child presents. It's not, I think it's fascinating. I mean, we could speculate why that is, and I'm going on a lot, and you must interrupt me in a minute. But I think part of the reason from running a clinic that was ultimately not financially viable, I can tell you that it is a hell of a lot cheaper to have a service that just sees everybody as the same. It will always be cheaper to say, oh, you're one of those, have some of this, than starting out from the position of what on earth is going on here? How can we understand the individuality and diversity of this child, and then fit a treatment program to that child? That's always going to cost more. It's always going to be more difficult to deliver that as a service. So I think there's also this the human tendency to try and reduce complexity to something simple and explainable. So, and then lots of pressures operating to obscure the reality of the individuality of these children.
In that vein, it's also important to mention that all these things are not mutually exclusive, right? You can be neurodivergent. You can have experienced trauma and have other comorbid presentations on top of the neurodivergence, and also you could have been exposed to drug and alcohol in utero and also experience some difficulties because of that, right? And all of these might need combined different approaches, but I think it's important that all these things are not, one doesn't mean you can't have the other.
Yeah.
And I think just to build on that and what Matt said as well about cost, though, is I think in the shorter term, it's cheaper to say, well, everyone has this problem, everyone has the same intervention. But actually, we know in the longer term, it's not. So many of the young people we saw in the clinic, and I know we're going to talk about a case study in a few minutes, have had really long-standing intervention that just hasn't been effective. Things have gone very, very wrong. It's cost social care, it's cost the NHS tens of thousands of pounds. Adoptions are breaking down. That can cost, sometimes hundreds of thousands of pounds. So it's not cheaper to do it this way. It's just cheaper in a 12-month period. And I think that's maybe the kind of the challenge of it.
Yeah.
False economy, basically. Yeah.
And it's interesting. This may be a little bit off topic. And I have a little bit of sympathy for why services do this, because if your health and you invest in the mental health over and above in the mental health of an adopted child, the savings don't routinely come to health. They may be distributed across education, social care, Department of Work and Pensions, if it has an impact on the family's ability to function and work as well. So, and Jim Clifford, amongst others, has done some very clever modelling of these accumulating costs if we don't help these children get effective permanency. So it's really difficult for a given service to take that risk, take on that cost, because they may not benefit from it. The world, society does, but no one's giving them any in the current climate or the recent climate of recent years. No one's giving them any financial credit for doing good. You're having to settle the wage bill at the end of the quarter, whatever. So yeah, I think it's tricky.
A term that so a couple of years ago, a colleague from Glasgow, Dr. Ruchika Goswami, who you might know, gave a talk and also was in Southampton and was talking about some of their work and some of the clinical work they are doing, and the term she used that kept resonating with me with kind of care experience young people was the kind of missed opportunities. So that much earlier there would have been an opportunity to diagnose the disorder that needed treatment more urgently, or that needed adaptations of the environment, for instance. But and then lots of these opportunities were missed until we had a very, very severe presentation and lots of additional mental health problems in kind of adulthood.
Yeah.
I think so often in our clinic in the NHS team, my favourite part of the work was we sometimes had these young people come in who were often around 8 or under 10, that kind of more primary age, where they had incredibly complex neurodevelopmental profiles, where things were really tricky at home, really tricky at school. And we were able to put that support in and turn it around. And, you know, those kids had excellent outcomes in a way that maybe you aren't able to necessarily do when someone's 18. Because, you know, when you've been in a really difficult pattern for 18 years, you're moving into adulthood, which is hard for anyone. And you've also got hormones and everything else going on. It's a lot trickier to do that successfully. Whereas, as you said, I think when you can do it with a younger child and not miss the opportunity, you can really make a difference at that point, which I think is so key as well.
And maybe talking about missed opportunities or not ideal history of treatment patterns and diagnosis. Shall we talk about Rosie? Rosie is the case example presented in the excellent health notes that we are urging all of our listeners to read, of course, but to make it a bit more palatable, maybe we can talk about the case you're presenting in the health notes, which gives an example, I think, what can happen if something is missed, something else is treated for, and what are the consequences, right?
Yeah, definitely. Is it helpful for me to give just a brief overview of the case as a starting point? Yeah, definitely. So Rosie was a girl who we saw in our service at the National Adoption and Fostering Clinic, who came to us when she was 16. And she came to us because there was lots of concerns around emotional regulation, anxiety, behavior, but also a lot of absconding behaviors. So she would disappear for days at a time and often engage in self-harming as well. So the family were really, really concerned. And I think what was so sad upon meeting Rosie is she was just so clearly on the autism spectrum. You know, she was a really, really lovely young person and is a really lovely young person. I still work with her now. But just, you know, a young person who walked in the door and clearly had autism, and her parents had kind of known that for years. They'd always thought she had autism, and they'd repeatedly gone to professionals and been told, no, she doesn't have autism, it's all attachment. And considering that they'd been fostering her and then adopted her from birth, for them that had been a really difficult message to hear, because they'd really internalized this idea of, well, she's only had an attachment with us, so if she's got an attachment problems, we've done something wrong. And that was a kind of a guilt that they'd been really sitting with, and a guilt that had kept being reinforced by professionals, that idea that they'd failed her in some way. And actually, when we did an assessment with her, not only did she clearly have autism, but she also had ADHD as well. And it was the interaction between those two factors that really explained her presentation. Whereas, you know, as we know is really common with young people with autism, she really struggled with anxiety, and she would experience it as really, really overwhelming, really difficult to manage, and therefore would go into a pattern of avoidance. And because of the impulsivity related to her ADHD, that avoidance often then ended up in her, for example, absconding, ending up in risky situations or kind of harming herself. And the attachment and kind of trauma style narrative and intervention that they'd had previously really was not sensitive to that. So all the advice that the parents had been given not only wasn't really helpful in her case, but often could actually be counterproductive. So, for example, they were told to be very, almost kind of forceful in how they socialized with her. So be really loving, really affectionate, try and initiate physical hugs, kind of talk to her all of the time about how she was feeling, which as a young person with autism, she not only kind of found incredibly overwhelming, but also didn't really understand how she felt lots of the time, and then found that really intrusive and really stressful. So therefore she really wasn't able to do that, and then instead ended up using risk behaviors as a way of managing her feelings. But then equally, what was really sad about the case was then we tried to get ASF funding after doing the assessment. And because obviously her difficulties were neurodevelopmental and not attachment and trauma related, there was lots of delays with that. And she made several really serious suicide attempts and was sectioned under the Mental Health Act for about a month. Actually, she was kept in a physical health ward for a month with 2-to-1 nursing. And it was a very, very challenging situation for her and her family. And whilst at this point things are so much better for her, so she's back in the community, in college, she doesn't present with risk behaviors in the same way, things are still very, very difficult for her and for her family. And I think what's so sad about this case, and I think something that the family have really recognized, is that if they were able to get that support 10 years earlier, they'd probably be on a very different trajectory now. But I think, as we all know, with working with young people on the spectrum, when people get locked into a pattern, it's quite difficult to get out of that. And when she's been in a very difficult pattern for 10 years of avoidance and not being able to engage with colleges effectively and being very isolated, at the age of now, she's 17 and a bit, you know, it's very difficult to make those changes to engage in life more positively and get that support. And I think that's what's been so sad about this case, whilst also really positive that she's doing so much better at the same time.
Maybe just to unpack a little bit for the clinically less inclined listeners, maybe. So we had a young person, age 16, who had an autism diagnosis that had been missed entirely, even though she was with their carers, now then adoptive parents, her whole life, right? But there was an attachment narrative basically from other kind of professionals. So they engaged in parenting strategies that were not ideal for what she would have needed. And also she had ADHD on top of autism, which you maybe should say is not unusual, right? That they co-occur quite often, right? And also she had anxiety problems, which also co-occur quite often with autism. But that made it even harder with kind of regulating her feelings.
Yeah, definitely. And I think we increasingly recognize that the experience of anxiety and autism is different to those who are neurotypical, and therefore you need adapted interventions. So if we're not recognizing that she has autism, understandably, how can services then provide her with the adapted interventions that she needed? And it was so important in this case to be able to recognize that, so then we could do that.
Maybe two things. I think I wonder whether it's worth stating that it's not, when someone has a diagnosis of autism, it's not about treating autism, right, or treating autistic traits, but it's about kind of making adjustments that make life for them much easier in terms of a disability model, right, and also treat the problems that are come on top of the autism, which is maybe a higher risk for developing anxiety problems, and then treat those kind of anxiety problems, for instance. Is that correct?
Yeah, definitely. And I think also with autism, there's an increasing, and all neurodevelopmental conditions, there's an increasing recognition that the emphasis needs to be more on environmental adaptation. So we need to take more of a proactive approach, because we know that many people with autism and ADHD are incredibly successful, do really, really well. And that's what we want. We want people to flourish. But for that to happen, we need schools and families to be able to make the adaptations needed. But obviously, they need to know that someone's on the spectrum or have ADHD to do that. But equally, as you did describe, we also know people with autism are more likely to have difficulties with anxiety and behavioural challenges as well. And they're the bits we want to kind of treat, as it were, or provide intervention for, not the core autism kind of features. But because that needs to be adapted, again, we need to know whether or not someone's on the spectrum, because we want to be able to provide them that kind of really specialist kind of neurodiversity affirming support, which we know is so key for them to do well and be successful.
Yeah, that's a really nice term, neurodiversity affirming support. Yeah, that's a really nice way of putting it. And also you touched on kind of that they were taught a certain type of parenting, right? Because they thought it was an attachment related problem, and we know the kind of parenting strategy that prospective adopters are taught is kind of therapeutic parenting, but in that case we can say this was not a helpful strategy. So I wonder if a young person, for instance, is autistic, what parenting strategies would have been helpful instead that might differ from kind of therapeutic parenting strategies?
As I said, more generally, though, I think it's about the need for these interventions to be personalised. So whether we're thinking about autism, ADHD, a child's temperament, child's age, any other factors, I think we're really wanting the emphasis to be on adapting interventions for the individual young person. And I think the challenge with therapeutic parenting or PACE parenting is whilst those things probably aren't harmful most of the time, because essentially it's telling someone to be a nice, caring parent, which is good. It's not personalized. It's not taking a child's individual profile and going, well, those bits for this child we need to tweak a little bit, because that's not going to work here. So for example, so many parents we work with where they have a young person who's on the spectrum, you know, you almost need to tone down your maybe your volume sometimes, tone down how much information you're giving the child at once, turn down how much you're trying to engage them in physical touch unless they want to, and just become much more kind of sensory sensitive in that way. You might need to be more literal with your language. Sometimes you might need to be using visual strategies to kind of support with kind of verbal communication as well. It might be around reducing uncertainty as much as possible. So, you know, visual timetables, routines, things like that. You know, it might be around helping young people to manage social situations that they find more difficult. And again, it's taking that much more nuanced approach, because whilst for some autistic people, they might need all of that, some autistic people might need only a couple of those things, or maybe not even any of those things. And again, it's that kind of personalized idea that we're really wanting to bring home here, that it's not a one size fits all approach. And that's, I think, a challenge with these therapeutic parenting ideas, is that's kind of how they're used.
Mm-hmm. So we have an incredibly kind of diverse population of caring experienced young people, right? And then even within kind of one diagnostic domain, let's say autism, then we have a very wide spectrum in there, and everyone, and obviously all autistic people are different from each other, right?
It's ironic, isn't it? I think when you think about what the attachment research tells us. So if you're wanting to do an attachment enriched, enhanced parenting approach, you've got to tune into the child in front of you. That's what all the research talks about. It's sensitive responding. It's tuning into the child in front of you, making sure that your affect and your tone is following theirs as much as possible. If you haven't got that understanding of the child being neurodivergent, then it's really, really hard to do that. So it's sort of ironic that some of these programs are off the shelf, kind of telling people you need to do this, 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 and this. Well, actually, you need to help develop the skills to tune into the child in front of you. That's what the attachment research would tell us to do. So I think if you want an attachment ready or sensitive parenting intervention, there are there are ones to go to. We did a bit of research a while back where we found that the most often delivered it's the so-called attachment programs have the least evidence base, and the ones with the highest evidence base, the ones most likely to make a difference, were the least implemented. So it was almost a perfect crossover in terms of evidence and their dissemination and application. So it's a shame, because it's not complicated what you do about supporting attachment on paper, but it is complicated if you're just going to be pushed into saying the same things all the time. That's a really important case Tom's talked about. It just made me think about a case I saw last week, actually. So it's still going on at the other end of the age development. These were a family with two very young children, I think at around below the age of 5, had been already identified with autism and ADHD, which is fantastic, because that doesn't typically happen in the adopted cohorts. That's brilliant. And the parents have done a really excellent job working out their child's neurodivergence and responding to both children's neurodivergence. But exactly the point you made, Dennis, that they're two children who are neurodivergent in quite different ways. So their quite complicated needs were not fitting well together, and actually they need a lot of they've done a huge amount of work on their own already, tuning into their child, working out what each child needs, but they're going to need some of that neurodivergent affirmative support, really, to help them build on that to the next stage, to stop the inter-sibling conflict. And the sad thing is, they had just been offered a kind of generic therapeutic parenting, which is not at all fitted to what their child's needs are. And it's just going to be a replication of the case that Tom said, you know. So it's even where these issues are really, really clearly identified, there's still something of a pressure to push adoptive parents back into the usual pathways of doing things that aren't really fitted to neurodivergence. So, you know, it's somewhat depressing. But
I mean, both of you actually said that the parents were actually aware that their children were neurodivergent, right? So
yeah.
is there a message to adoptive parents or foster carers maybe to trust your gut on these things?
Yeah, adoptive parents often, they understand better. We should listen, goodness knows. Again, we did a bit of research on adoptive parents satisfaction with services, and the big area is quite a lot of dissatisfaction with services, to be fair. And a lot of their dissatisfaction was based on collaboration, information sharing, and sort of being listened to. And I think that we've got quite a long way to go across all services of actually, and for actually all parents, making sure we listen to what parents say and bring our knowledge, clinical knowledge in, but also respect the fact that the parents are the best sources of evidence about what their child is like on a day-to-day basis. Problem is that knowledge both sets of parents had is going to be squashed out by the top-down belief. Adoption is attachment, adoption is trauma, and they're just going to be pushed into a pathway regardless of what they think. And I think if you're a parent and you trust your gut and you say, this is not right for me, that doesn't always go very well. We've seen plenty of parents who've tried standing up for a different perspective for their child's needs. And sometimes it goes down really well. You have fantastic practitioners working with them and helping them to achieve those aims. And then sometimes you don't. So I think it's pretty difficult to stand up and follow your gut and assert what you think your child needs. Plenty of burnt out adoptive parents who've tried doing that.
Especially if you're fighting against the system, aren't you? That you know, as one set of parents to change the system, it's quite a big thing to go up against. No,
It's the both, isn't it? Like, you know, it's not saying it's not attachment and trauma. It's saying it could be attachment and trauma and autism and ADHD, or one or two. And it's just thinking about that in a more nuanced way. Because I think some families just need an easy win. And I think sometimes, you know, identifying ADHD and helping a young person getting on medication is not going to solve everything, but it might be a bit of an easy win that makes things a bit easier. Or identifying autism and helping them get into a special school so they're so much less stressed at home, or they can get more support in the school they're in. Again, it's an easier win, and it might not solve the whole picture, but it can just make such a change. And I think that's the real message.
Definitely, I like the idea of an easy win, because then what you do is you release the therapeutic potential of parenting. You know, those parents' therapeutic potential is kind of being inhibited by these hidden difficulties. You get them identified, you take some of the heat out, some of the difficulties out of the situation, and then the if you like, the natural therapeutic potential of parenting can come through. I think therapeutic parenting doesn't have to be a program that you follow. It is, a lot of research shows, stability in and of itself is therapeutic. So if we can actually make that happen and sustain, that's the real business of therapeutic parenting, I think.
Because I know Vicky is starting to ask you some questions about your letter you submitted to the journal. I just have maybe one question in terms of advice to maybe adoptive parents who suspect their child might be neurodivergent. And you said your second case was a case where children were quite young. So what is kind of the age where from which on we can actually identify, let's say, ADHD, autism? So what's the typical age range this could be diagnosed from at the earliest, maybe?
I mean, for the family I was thinking about, they're lucky they went through pediatrics and health, and to some extent stayed away from mental health and social care and education, because, you know, the pediatricians looked at these children and said, well, it was quite a straightforward diagnostic framework. Whereas once you get moved into a different sector, they might start having all these other theories and hypotheses about what's going on, all different to each other potentially, but also different to the sort of a neurodivergent approach. It's a bit of a lottery out there. I mean, it's not just a postcode lottery. I think it's even more complicated than that. It's a kind of intra postcode lottery, depending on who you see and what their ideology is. And it shouldn't be like that. You know, it should be much more standard. And I think 2 weeks ago, I was part of a group that launched 20 recommendations for thinking about care experience children's mental health needs, with Golm and Bath, amongst others, the UK Trauma Council. And, you know, maybe families can have a look at that. Maybe they can have a look at this, these recommendations, because they are recommendations that are agreed amongst clinicians, social care professionals, and academics. Maybe families could use those principles, which are, you know, get a decent assessment. You should be allowed to have entitled to a decent assessment. That's the cornerstone of it, really. Getting a decent assessment, and the decent assessment is one where take an evidence-based approach and keep their mind open, and not just say, "Oh, you're one of those," because there is that tendency to go, "Well, it's adoption. You fit in my trauma bin or my attachment bin, or my, you know." So get a good assessment if you can.
And age-wise, when should this assessment happen? So can we diagnose it in, let's say, 2-year-olds, or is it much more reliable from age 4 onwards, or is it better if they are in school?
ADHD is an interesting one because you know there's guidance around the age of 6 years for medication, but you can identify if a child is really presenting severely. We've diagnosed it in 3-year-olds or 4-year-olds, really impaired children. So you know there is a bit of guidance about that, but it's still possible to identify really early if it's very clear, absolutely, and that can be really helpful. And it's also possible if medication is indicated to medicate a younger child. But what we've seen, because we were a national service working with kids all around the country, is some places have responded to those ideas, saying, well, you won't diagnose anyone before the age of 6. And then I'm thinking one area in particular, I won't say where, and then they don't offer any assessment during the rest of the primary school age, and then it sort of comes back in again in the teenage years in a different part of the service. So sometimes services are organised locally in a way that makes it extremely difficult to get an assessment. So yeah, the simple answer is you can identify really marked ADHD from a very young age. Moderate ADHD is easier around about after the age of 6 because one's attention and concentration and just tends to take off around about that time. So it's easier to diagnose. And something similar is true for autism as well, that some of the social communication aspects take off around about 4 or 5. But again, you can identify it in much younger children if you've got people who are trained to do that. Then there's the whole issue of getting an autism assessment nowadays is
well, some people might listen to this and find the idea of diagnosing kids that young slightly off-putting or feel, you know, like they disagree with that. But I think it's the key point that you said there, Matt, about it being marked. You know, we're not talking about kids where everything's kind of going okay and people are curious whether they've got a diagnosis or not. You know, we're talking about kids where adoptions are potentially breaking down, even though the kid's only 4 or 5, or the kid's already being excluded or expelled, and actually doing the assessments at that stage, getting the correct diagnosis and the right intervention, then can prevent that from happening. And actually then you're saving the young person and the family from a huge amount of trauma because you're managing to put things on the right path at a much younger age. And I think it's just important to highlight that, because I know some people might find that idea a bit off-putting, but we are talking about kids where things are very difficult for everyone involved.
The diagnostic criteria for ADHD say that there needs to be really significant impairment across at least 2 domains, right? So that means, for instance, let's say school and home life, for instance, right? So we're talking at families who notice problems across, you know, quite significant problems.
Yeah.
And maybe because you mentioned medication, and I know there's sometimes hesitance, or, you know, people might be a bit worried about ADHD medication, for instance. Can we reassure people there?
Tom and I are psychologists, so we don't prescribe, so we have to be sort of be careful about saying too much. But I would say we've seen it have fantastic impacts on children in the clinic. You know, a well implemented medication regime is going to be carefully monitored to show that it's having an effect. A good psychiatrist or paediatrician will also follow up and make sure they're giving the lowest effective dose. And they're very safe medications now, aren't they? So I think we can reassure people, but I think most people, and I think the stories people hear are more about maybe the US. It's a different sort of context here in the UK. I think it's harder to get the medication, and I think it's implemented in a sort of safe and effective way, and especially if it's monitored to make sure it's the lowest effective dose.
And also thinking about the pros and cons, you know, if you've got a young person who's engaging in really extreme behavioural challenges where they're going to be excluded from school or is potentially absconding, and we've had a few really sad cases of young people with unmanaged ADHD absconding and then, you know, awful things happening, you know, those risks surely far outweigh the downsides of trialing a medication that's been well managed by a psychiatrist. And, you know, stimulant medication for ADHD has been used for probably about 50, 60 years, and it is known to be a very safe medication. And I think it's about weighing that up with a professional and thinking, you know, which is the bigger downside. And that will be a different decision depending on the young person, depending on the family, of course, as well.
If you were to look at another condition, like epilepsy, for instance, most people wouldn't think twice for a child to have epilepsy medication to keep their seizures under control. So Perhaps something we need to get past as well with ADHD, that if it helps the symptoms they're presenting with, then it can be a good thing. So,
Yeah, historically, the UK, we used to talk about hyperkinetic disorder, which was like it's ADHD, but it was a much more kind of severe presentation before it kind of met threshold compared to perhaps the States. And I think, if you see a child who's got marked ADHD, you don't forget it in a hurry. I mean, there's this sort of idea sometimes that, everyone's got mental, I don't know, so in certain sectors of society, everyone's got mental health issues nowadays. But honestly, there are some things when you see them, you just see how impairing and how challenging they are. And when it's severe, it's not really unambiguous. It's pretty clear. So yeah, I agree with you.
But also, I think you were recently asked about this as part of a symposium, that kind of risk of overdiagnosing, and the point we were making was, well, but in certain sectors we're underdiagnosing. So we're underdiagnosing autistic girls, for instance, right? And we are underdiagnosing neurodevelopmental diagnosis in the care experience population. So and I think that is what people are sometimes forgetting when we're talking about this. But we need to talk about your letter as well.
Yes.
Because over to Vicky and talking about the letter now.
Yeah, just a little bit of acknowledgement of your letter, because that is going to appear in the same issue of Adoption and Fostering. It's about the Adoption and Special Guardianship Support Fund, formerly the Adoption Support Fund, and the service spending, commissioning of services, isn't it? So just to acknowledge that it's also Carmen Pinto and Stephen Scott from SLAM as well, South London and Maudsley, as well as you two. So just basically you're talking about a freedom of information request. Before we get that, just to kind of think a little bit about the funding cuts, because recently there's a possible pot used to be £7,500, right? And that's now gone down to £3,000 to include both assessment and any sort of therapeutic support that might come from that, which is a massive drop. How have the government kind of reached that figure, do you think? I suppose you don't know 100%. And just kind of connected to that as well, what's the impact going to be from your perspective in the work that you do on children and families who might use the fund?
I think when you look back to how they came up with the fair access limit, they were quite clear that at that point, because it was prior to the fair access limit coming in and what was then the Adoption Support Fund, you could actually do all the assessments that were indicated and the treatment that was indicated. It wasn't capped. Then the cap came in. That cap was essentially, they looked at how much had been spent, how many contracts there were, and they divided them up and they came to that number. This new figure, what we can see actually from the Freedom of Information data, is if you take the amount of money that's been spent and divide it by the number of contracts, you get about £3,100. So I'm guessing the similar process was undertaken, which at one level, if that is the case, at one level, I see there's a bit of sense in that. But where it's not sensible is that not everyone has the same needs. We know.
Yeah. Back to the same thing we've been talking about, isn't it? Diversity, and truly meaning diversity when we say it. Diversity not being a label in itself. Yeah. It's
a real thing. It's a real biological, social variation that is meaningful and not just a stance. It's real variation there. And then it's just homogenizing people and making them into blobs and lumps. And that's a shame. But what's its practical impact? Well, one that we found over recent years, it was getting harder and harder to make a case for assessment. And you cannot effectively treat anybody, including adopted children, special guardianship children, effectively unless you know what they've got. I mean, your doctor wouldn't just give you drugs before doing an assessment to find out if you had hypertension or asthma or something. You need to work out what the issue is. Then, having worked out what the issue is, treat it effectively, measure that treatment, make sure it's working. So getting assessments done has been difficult for many years, especially getting assessments done that are broad enough to look at the whole range of possibility that the child has. So I think the biggest impact is going to be on people aren't going to get assessed. There's going to be even more of this tendency to say, oh, you're adopted, have some of that. and they're going to skip. They're going to skip through the assessment, and if you skip through the assessment, then you're going to get less opportunity as a parent to try and influence or prioritize what your child's needs are, and then try and fit those needs to particular treatments. So I think there'll also be the issue that there'll be less treatment available because they're cutting the amount of money so much, which would suggest that you're probably going to get cheaper treatments, which would suggest you're going to get ones which aren't necessarily the strongest and most robustly evidence-based, given in a sufficient dose to make a difference. So that's going to be an issue. But I think also, assessments are going to get really hit, and that's not helpful.
Very first stage of the process.
Yeah.
Gosh, yeah. So your freedom of information request that you make, can you tell us a little bit about some background and what it was?
Well, we were curious about it's a lot of money. It's nearly £500 million has been spent by the Department of Education on the mental health support of adopted and latterly special guardianship order children, and some other children on other types of permanency arrangements. So,
and over what kind of time scale?
10 years.
10 years.
Yeah.
Yeah.
So I think it's around 450 million. It's difficult to get the precise numbers. Probably people know them, but it's difficult just to get the precise numbers. So we got it up to January this year, 130 odd thousand contracts, and then we wanted to see who were the providers most often receiving the money through the adoption support, the special guardianship support fund, and very clear message coming through that it was the third sector and private sector. So 95% of that money was being given to individuals from private practice, third sector organisations and private companies. As far as we could tell from the information that was there, about 4% of that money local authorities were using to commission local authority services, and then 1% of it was going to the NHS. I've been in the NHS for many years, so you could say that I'm biased. I think if you've got mental health issues, and mental health services in the NHS might be a first port of call. I guess some other people might say, well, we wanted to stimulate the market in new and innovative ways, and they've probably done that. But if it just feels like there's been a lot of experiments done there for adopted children. If people are innovating and doing new things that haven't been tried and tested, and don't have the sort of the evidence to back them up or the governance to ensure that they're working effectively, then there's a risk that there's been a big experiment. But it's actually a big experiment in which outcomes haven't been measured. So it's a pretty rotten experiment from a scientific point of view. I mean, I think it just needs to be, people can form their own opinion of it. So there might be some people are saying, thank goodness we spent all this taxpayers' money on the private sector, that's great, and so little on the NHS. And there'll be others saying the other way around. I am biased. I do think the NHS would have been a good way to have to invested some of that money, and some of that money should also have been used to evaluate outcomes effectively, clinical outcomes effectively. That hasn't been done. The assessments of the Adoption Support Fund would not fit into a kind of health evaluation framework, unfortunately. So we haven't got a lot of understanding or knowledge about its effectiveness, despite all this money being put into it. So, I'll stop there. It's a lot of money, and it's been going to very, very, a range of services, and very, very, very little of it going to the NHS.
But I think as well, the challenge of it going to the private sector is so often so disjointed. I mean, so many families that we have worked with have been seeing private people via the ASF, and then CAMHS have said, oh, you can't come into CAMHS because you've got a therapist elsewhere. And then the challenge is CAMHS does often, not always, but often you've got that multidisciplinary kind of approach. You've got people with different areas of expertise. They can look at things in a more complex and nuanced way, at least in theory. We know that's often not happening in practice, sadly, due to lots of issues we won't go into now. But often, therefore, it being separate and disjointed has become another barrier for these kids being able to get into services, which again I think is something we're seeing so often, and I think is really problematic.
Brilliantly said, Tom, and it's also because there's a different narrative. And one of the things we've noticed for years now is that the adoption and to some extent broader care experience world has some different narratives to mainstream evidence-based mental health care. And probably the narrative differences have been exacerbated or accelerated by the Adoption Support Fund going into private sector services using innovative treatments. And so even if you manage to get seen in CAMHS, if parents go in and they're talking the same language they've been encouraged to talk about for the previous years, CAMHS can just say no, because you're talking a different language.
Right.
Underneath that language, there should be common elements. I think one of the most fascinating bits of research we could do in the future would be to look and see how we can link up these types of languages, because they are different. You don't get an easy route into a very stressed and restricted CAMHS service if you're coming in and talking about sensory processing issues or some other sort of adoption specific thing, because that is not part of the world of evidence-based practice that most CAMHS services are organised around. So it's pretty difficult to get joined up because we're working with different narratives. If that makes, I think that's an important thing to think about.
And the financial pressures as well. Well, I think it is important to name that there is a benefit, isn't there, with all of this money around, to be able to say, come up with your own therapy and brand yourself in a certain way, because there's hundreds of millions out there to be grabbed. I think there's less maybe a pressure on formal evaluation and showing what actually works and, you know, publishing high quality research, because, you know, if you can develop something that's innovative and you can say, well, this will help all of these kids, which we are seeing a lot, then you make a lot of money out of that. And I don't think that's helpful when, again, as Matt said, these are kids that we're kind of experimenting on a little bit. And they're children who are the most disadvantaged in society anyway. And I think we need to be giving them the highest quality support and maybe take away some of those financial drives and make it more around helping these young people and families.
Okay, so just to clarify, you're not saying we don't need the Adoption Support and Special Guardianship Fund, but you're saying, you know, money should be invested in this sector, but it should be spent to support evidence-based therapies where we know those work and are the right ones for children. Is that young people? Is that
Definitely.
fair?
But we have to be mindful that the commissioning context has taken a big strides away from evidence base over many years. I mean, when I started in this over 21 years ago, there was already quite strong narratives around that were not commensurate with the evidence base, despite there being a good evidence base that you should be doing the usual things for adopted and foster children. So there is, I think, it's quite a lot of work, reparative work, that needs to be done to help join up thinking across sectors now. Yeah, I don't know. It's quite difficult to have conversations about the evidence base, I think, because we'll find people saying, well, I've talked to 3 people, they think this, and that they think that's the same standard as, you know, an RCT or meta-analysis of RCTs. And you might not like the idea of randomized control trials and that way of doing things, but, you know, there are different kinds of evidence, and people aren't maybe, sometimes you see in the commissioning process, people aren't really aware of different kinds and quality of evidence and how it actually could help inform the best interventions for young people. I'm trying to be diplomatic. I don't want to be very good at it, but it's yeah, I'm not hopeful that we're in a place to just say, let's just do the evidence-based stuff, because I think people are talking different languages.
Maybe just to clarify, randomized controlled trial, we mean that's a special type of research design, right, where we are at random, you know, saying, well, this group of people enters this condition, which might be the therapy we want to test, right, or the intervention we want to test, and the other people enter a comparison group, which is a control condition, which is deemed non-effective, right, but which controls for certain things that we need to control for in this vision. And it's very robust design. It's a gold standard to showing efficacy of a treatment, right?
So there's less chance of, you know, most of us have little biases here and there, which can add up to bigger biases. So it just tries to control for things that might be, you know, inadvertently explaining some of the effect.
Yeah, and I think just to put a positive spin on it as well, because I think, yeah, we are definitely supporting the Adoption Support Fund, and I think it's recognizing that there is still a lot of money there, less than there was before, but there's still a good chunk of money there. But this is an opportunity, I think, for us to think, how can we spend that money to actually improve these kids' lives. Because I think so often there's a really sad narrative that we see of, oh, you know, adopted children have these difficulties. They're always going to have these difficulties. There's nothing we can really do about them. And it's more kind of supportive treatments, almost, you know, a slightly kind of just, well, this is the reality. Let's just try and make their lives as good as we can do kind of approach is often what we see. And I think we find that quite sad, really, and really heartbreaking, because we know that if you do provide effective evidence-based care for these kids, they can do really well. And we've had so many children who in a really short period of time have, you know, things have changed hugely for families and things can be really positive. And I think that's what we're wanting to inject here, this positive message of these kids, lots of them can do really well and can be really happy, and these families can be really successful, but with the right evidence-based support. And we want to move away from this kind of approach of just kind of going, well, this is the reality, so let's just give them something.
Evidence-based and also tailored support, right? What we were discussing earlier, that is not a one-size-fits-all approach, but the approach that we should try first is not should try, but that should be used as the evidence-based approach, and that can then be tailored to strategies in the individual case and the complexity of the presentation, right? I'm a bit conscious of time.
Yeah, I was going to say, I think it's really nice actually to finish on a positive note, and that's a nice place to end. But it's also really, yeah, I mean, everybody in the sector wants to work together to do that ultimately, don't they? They want the best outcomes for the children that we're talking about, and that's really key. I feel like I've learned a amount from this, so thank you very much. Thank you very much for joining us. And Dennis, it's been amazing for you as your area of research as well. It's nice to delve into. Thank you. And again, for our listeners, you're a member of Quorum Bath, you get access to the journal as a benefit. And we'll see you soon.